Well, thank you very much. I've been studying quality for about the last 12 years, but I've actually never been asked to give this talk. So I'm going to put quality improvement kind of as the filling in the sandwich, because what I know about quality improvement, honestly, you could fit in a thimble. And for those of us who trained at like WashU, you've probably heard that before. But it was interesting, the day that I was asked to give this talk, I was actually on a website for quality improvement for surgeons, not specifically for surgeons, but I'm going to talk about that today. So I thought it was just interesting timing. So if you talk about quality, this is the best thing that I've ever seen. If you want to get a hip replacement in Sweden, if you're a hospital performing hip replacement in Sweden, these are the outcomes that you have to show. You have to show this health gain index after 1 year. You have to show patient satisfaction at 1 year, complications at 2 years, and 10-year implant survival. So if you really want to pass the sniff test of quality, I've never seen anything better than that. And there's nothing in the US that comes close right now. What's interesting, obviously, is they have a different healthcare system, and you have to do this or you don't get paid, right? So it's a big stick. Small carrot, big stick. 90% of the Swedish hospitals doing hip replacement have complete, publicly reported data on these outcomes. As we said, it doesn't exist in the US. Okay, so that's going to be the bar. We obviously are not there, but I think we're making strides. So what have we done in thoracic surgery, right? We're very proud when we work with our STS and other databases, and we make models, and we try and look at kind of the quality of care that we deliver as thoracic surgeons. We recently updated the lung cancer resection model. We all know that there are some kind of low and high performing hospitals such that their confidence intervals don't cross 1, but the vast majority of hospitals are kind of crossing 1, and that'll become important when we talk about star ratings. I would imagine there may be a few questions about that. So we know that we've successfully measured and compared in-hospital and 30-day outcomes for major complications and for death. But we don't come close to the Swedish hip arthroplasty registry. Okay? So we don't have long-term survival for cancer care. If you're an STS participant operating on like a clinical stage 2 lung cancer, and you do a wedge resection with a positive margin, sample no nodes, and the patient goes home on day 2 and stays home, you look like a superstar. So that does not pass the sniff test. I would imagine in the 5-year survival category, you're not going to look so good. So we've added that as of 2015. Just for a note, you don't wait 5 years to add that. You're supposed to do that every 6 months, and we can talk about that some more, but your hospitals can help you because the cancer registrars at 80% of our hospitals already collect these data. We also lack patient-reported outcomes. They're getting a lot of press now. I know Mayo has been doing some work in the esophagectomy group. At UVA, we did some work with lung cancer, and now at WashU, the PROMISE system has essentially gone live about 3 months ago, and there's a phased rollout such that everyone seen in the cancer center will be filling out PROMISE surveys before they get seen by their physician. And when their physician sees them in the clinic, or I should say health provider, it won't be all physicians, it will be essentially already on all scripts, soon to be Epic. And thoracic surgery goes live next month. So I'm not going to ask for hands, or I'm not going to make you step on your left foot and jump up and down, but it's important. How many of us in the room really look at our biannual feedback reports? And I'll agree with you, those don't look so good. So we're trying to change them. You know, it started off as kind of a descriptive database, and I think we've come a long way over the last 12 years, so we're going to try and make those much more user-friendly. But the other important thing is, it just the chief who sees the report, or do all the surgeons, does the whole team see the report? And do you actively talk about the report? You know, so if you want to talk about quality improvement for surgeons, there's got to be a culture for quality improvement. And it starts with looking at the results that you can at least quantify. The other thing I found out, you know, the first time you become the head of the STS Thoracic database, you get to go to the AQO meeting, Advances in Quality and Outcomes, and you stand in front of the sea of data managers, and they ask you questions, and you give them kind of solid answers, and then they pull up on the website the definitions, and you're wrong on every answer that you give them. It's very humbling. It's a fierce group. They really try very hard to be accurate and be good. What's scary is that a large percentage of them have no interaction with the surgeons on their staff. You know, so something to consider. If you don't know who that person is, reach out to them, because they really want to help you. They want to do a good job. So we have to work with them, and a lot of us are not. So it's a little hard to see from the back of the room, I know, but this is a great website. So this is the website that I was on when I got the invitation to give this talk, but it's the Institute for Healthcare Improvement. And Don Berwick ran this before he became head of CMS, and it's really taken off. But if you really want to talk about quality improvement for surgeons, it's a tough task. I mean, how do you actually get something done? This is a very practical website. So I would highly recommend, if you're going to take one thing away from this talk, Institute for Healthcare Improvement, and you can all look it up, and you can search whatever interests you. Very practical. They really give you some nice examples. So I'll go through one. So here it is, how to improve, right? You have to form a team. You've got to, everyone has to know each other. Then you've got to have some shared aims, establish measures, right? If you're going to actually measure quality improvement, there's got to be something measurable. People still struggle with that, unfortunately. Select change, test change, implement change, and then spread change. They'll actually go through each of these steps with some very practical ways that you can succeed. And then the methodologies for improvement science, you know, it's dizzying, and we hear about Six Sigma and other, you know, lean methods and things like that. They've really moved toward this thing called the model for improvement, which makes a lot of sense, and we actually have just instituted it at WashU for a program. We were looking, I wrote a paper at UVA on our esophagectomy patients, and we studied their kind of nutritional assessment at the time of surgery after they finished chemo RT. And it was horrific what we saw, you know. So we'd put J-tubes in them, and 50% of patients never used their J-tube pre-op. We would see them, we'd discuss nutrition. They never actually spoke with anyone. They never spoke with anyone during their induction therapy. So that's our current topic, and we're trying to use these PDSA cycles. So here's the model for improvement. You know, there's a few questions, like what are we trying to accomplish? How will we know a change is an improvement? And what change can we make that will result in an improvement? And so it's a pretty simple cycle. You want to plan, you want to do, you want to study, and you want to act. So plan, right? You got to plan the test, including data collection and the other steps. Really important to be very specific. What is your objective? Find something that's important to the stakeholders who are going to participate in your quality improvement process. Then you're going to develop a plan to test the change. That includes, you know, who, what, where, when, and what data do you really need. And I'd also suggest, you know, I've seen kind of a resource-poor attempt and a resource-heavy attempt. You've got to, you know, your local culture is going to help you pick what types of quality questions you want to tackle. And then second is to do. So I think we get kind of wrapped up in this analysis paralysis, right? Just start something simple that you can actually do. And if you fail, it's okay. You can learn from failure. They really talk about this quite a bit. 3 is study. You know, complete data analysis, compare your outcomes to your predictions, summarize what you've learned, and then there's something called a debrief in these cycles, and you figure out, you know, how you want to do things differently the next time. And one of the things that I learned about, I'm just curious, has anyone here ever made or used a run chart? Few people. So I hadn't. Here's an example on their website, and we just started one for our quality improvement process, but this was an example taken where ED wait times were too long, and they wanted to figure out how do you shorten them. So you've got to set a goal time, and they set it at 30 minutes. That's the orange bar, the horizontal bar. Then they track times, you know, the wait times over time, but they're annotated. So those little kind of black check marks and the words are some kind of intervention or something that changed over time. So you can start to visually see what impacts the outcome. We had an issue where, you know, there's that new quality metric of 10 lymph nodes, and we have some pathologists at our institution there's no lymph node counts. And so, like, what do we do? You know, and there are some surgeons who do dissections, some who do sampling. So we just started one of these where we actually now set up 12 cups at the start of every lung cancer resection. And so if the cups are empty, then you know that there aren't nodes in them. And if you have a different cup for each node and you send it separately, then you're probably going to get a node count. But there's been 3 attempts to make this better, and all have had small incremental gains. So we started this chart to see what happens. Like simple things, they don't all have to be complicated. Then 4 is act, right? So you've made some kind of change. What do you learn from it? And you've got to determine what you should change as well. You know, adapt, abandon, or adopt. And then you're going to essentially go right back into the next cycle. And so they have this little picture on the thing where you're starting with an idea and you do kind of roll the ball uphill, and eventually you're going to implement this not just in your own little group, but kind of system-wide, or perhaps in the STS, where it would be kind of nationally. And it's really a simple idea, and they really go through it quite well on the website. So I am not a quality improvement guru. I am new to this as well, but we've had some success, and I would strongly recommend that you guys check it out. Now I'll move back into what I'm more comfortable with, which is quality measurement. So some of the things I thought that you may be interested in were some of the advances in the kind of things that we've been doing with the STS. So I think everybody knows that both the lung and esophageal cancer models were updated in 2016. They're both in press, so you can read them. Importantly, we've added 5-year survival for lung and esophageal cancer resection. You know, we're still not going to make kind of the outcomes of the Swedish hip arthroplasty registry, but we can do better. And so it's important because people are thinking that their secretaries or their data managers are going to have to reach out to all these patients for 5-year outcomes, and you really don't. It's probably 1 phone call and 1 meeting to your cancer registrar. So there's 2 systems. You have an STS database. They use the National Cancer Database. To merge that for both databases is problematic, but we're trying so that you don't have to do it on an individual level. But for right now, pretty easily you can share those names, birth dates, etc., and you can match these patients up and you can get the survival for these patients pretty easily. We have it now automated, so every 6 months it's updated. Note, if you do use the cancer registrar, they're only required to update the survival every 14 months. So we're submitting every 6-month data. So every patient won't be updated every 6 months. That's okay. You have a last known date of follow-up and then vital status at that last known date. So you don't have to update every patient every 6 months. The other way we can do that is you know, I think we've all heard Felix Fernandez, who's the PI on an AHRQ award, who linked Medicare data with STS data. That's a great way to do it. The only problem is that you end up getting about 60% of the lung cancer resection patients 5-year survival. So very good, because you can get a lot of other interesting kind of outcomes that you get from MedPAR data, but you're losing about 40% of your sample. The other thing we have to work on is incorporating patient-reported outcomes. Really does make a difference, particularly if we're talking about robotic lobectomy and VATS lobectomy and thoracotomy. It'd be interesting if there really is much difference of these things, short-term, long-term. There's different ways of looking at it. The other thing we have to think about is, sublobar or even lobectomy versus SBRT. So every time people talk about patient-reported outcomes, we think about it with kind of that lens of a hip replacement, that patients are going to have this poor state. We're going to do an intervention and they're going to improve. But we don't see that so much for lung cancer resection. At least most of our patients are asymptomatic. So we're actually going to make them worse, and then hopefully they'll get back to the same state. So it's a very different paradigm. Nobody really knows how it's going to look, and we're going to have to do the work. For esophagectomy, you'd expect that that would look different than it does for lung cancer as well. So the STS understands this. There's a big push. They started a patient-reported outcomes task force last year, which is kind of in full force now. We're working with actually the people who have developed PROMISE in Chicago. And there are kind of 2 projects. We just submitted an R01 to ARC to study it in a sample of hospitals performing lung cancer resection. And then there's a big push in cardiac surgery through the Michigan Cardiothoracic Surgery Collaborative. So that's, I think, 17 or 18 hospitals that are already meeting quarterly, and it's a great kind of local place to try some of this. Not all the hospitals are going to do it, but most. And then, as you know, public reporting is actually live. It went live this January. And we try to be very thoughtful about this because we know that it's very different in thoracic surgery than in cardiac surgery. Like the penetrance of the cardiac database, 95% or something of all programs performing cardiac surgery participate in the STS. For thoracic, it's much lower. It's probably around 40%. And so we don't capture all the cardiac surgeons who are doing thoracic surgery. We don't capture most of the general surgeons who are doing thoracic surgery and the surgical oncologists. So it's a very different environment. So we have this phased rollout. So if you go on the website, I think, I'll go back. But if you go on the website, the first thing you're going to see is a listing of all the programs. So it's kind of pay for participation. So we've shown that the STS outcomes outperform national benchmarks. And so the first two things that we're showing are the programs who participate in the STS outcomes, and then group comparisons of the STS versus the national inpatient sample, which is an approximation, the best approximation we have of what's happening kind of with lung resection nationally. The next phase, which we've all just gotten the emails, I know at WashU we just signed up, hopefully some of you have, to participate in true public reporting, which will be the next phase, starting with just the lobectomy model for lung cancer resection, and hopefully a year later, the esophagectomy model for lung cancer resection. And we presented that at the STS last year, and that paper took quite a while. We actually presented at the STS in 2015, January of 2015. Took almost a full year to get it in press. That was a very interesting process for me, but different, probably a different talk for a different day. And then there is the website. But I think it's, it's really important, and I know there was a question for Dr. Reddy earlier about kind of, if you just look at the high volume places, is that really kind of a accurate snapshot of what's happening in the world? Well, it's a big deal for the STS too, because we think that we're kind of providing better care than the country as a whole. But even in the STS, 25% of programs don't do 10 lobectomies for lung cancer a year. I don't think that's a very high bar. But if you go to publicly report and give star ratings, you have to be confident in the quality of care provided by a provider. If you don't know enough about that provider, then you can't give them a star rating. So a quarter of our programs don't get a star rating. I mean, to me, that's a big deal. And it's not going to pass the sniff test with CMS either. And then you could go to esophagectomy, it's multiplied. Half of the programs don't do 5 esophagectomies for cancer a year. So it's a big deal. Those are the two things that we've kind of decided we really want to study and model and show the outcomes, so we can really figure out how we improve and, at least reach benchmarks, or, nobody in the audience thinks they're average, so we're all supposed to surpass the benchmarks. But it's a big deal when only, half the programs don't do 5 a year. So we got some big hurdles in front of us. And so this is my son on the beach with his pail. I just want to thank everyone for the privilege of speaking here today.